I know it's the first symposium of the Congress, and it's a big auditorium to fill, so thank you very much indeed for being here. This year's theme is Surgery in the Digital Age, and we're really going through a revolution in the use of technology and data to understand what our outcomes are, what our workloads are, and that revolution has got a long way to run. We're trying to raise the profile of all the issues, and I'm very grateful to the 4 speakers who've come along this morning. Professor Dorry Segev from Johns Hopkins University, who's going to talk about his expertise in simulation of medical data, analysis of large data sets and outcomes research, with particular reference to his experience in transplant surgery. He'll be followed by John Abercrombie from the Royal College of Surgeons, who is going to talk about the challenges, which are considerable, of data collection to understand how we can get it right first time. Then Ian Buckingham has very kindly come along to talk about the experience of the laparoscopic and upper GI surgeons in collecting data through the SWORD, the Surgical Workload Outcomes Research Database, which is acting as a model for a lot of interest for similar developments in other specialities. And then Jem Rashbass, who's very kindly come over from Cambridge this morning, is going to talk about the creation of the National Cancer Registration and Analysis Service out of the various regional cancer data collection systems and various other tools available to him. We've got a fairly tight session, 4 speakers, about 20 minutes each. I think we'll move on without questions. What I'd like you to do is to make yourself available to talk to the speakers at the end of the session if you've got any burning issues. We're going to try and capture the session as well in outputs, which will be released to the wider membership over the next year or so in multimedia format and also in written format. So if you don't capture everything today, hopefully you'll be able to read about it later on. Thank you very much for coming, and please enjoy the session.
I'd like to thank the ASGBI for inviting me. I'm not surprised there aren't many people here. It's 4 a.m. I'm going to talk about the use of big data in solid organ transplantation, and hopefully we'll give you some examples that can generalize to any specialties. So what's the big deal with big data? Well, the nice thing is that we actually have a lot of it, and we have a lot in transplantation, but there's more and more growing in each of the surgical specialties, from national registries to insurance claims to pharmacy claims. Every time we sort of do something to somebody, somewhere those data are generated. Now, we may not have access to all of them, but eventually we'd be able to. And the sample size is humongous, which means you can make all sorts of interesting inferences. The collection is usually either automated or mandated, thereby the data quality where 20 years ago we would consider big data to be garbage in, garbage out. The data quality today are actually quite good. There's no selection bias, which means you generally capture the entire population that you're looking at rather than just people in an academic center who decided to participate in a study. And the ascertainment can be highly reliable, particularly of outcomes through linkage, and I'll talk a little bit more about that as well. I'll give some examples of how we've used big data, data drawn for purposes other than what we used them for, to inform policy and motivate the US Congress, which you know can be challenging, to compare effectiveness with regards to incompatible transplantation, to do linkage studies for estimating kidney donor risks, and some decision process modeling to help patients decide which organs they should accept and which organs they shouldn't accept. And to offset the mathematical and technical nature of things for the other side of your brain, I'll share some of my travel photos as well. So this is from Patagonia, and this is my reminder to introduce you to the sensitized patient in transplantation. So on our waiting list, there are about 30,000 patients awaiting kidney transplants who are sensitized to HLA or ABO. Either because of the blood type that they are or because of exposure to HLA from non-self, from blood transfusions, pregnancies, previous transplants, et cetera. And for these patients being highly sensitized, it means that their chances of finding a compatible deceased donor are very low. And even if they have a living donor, if they're incompatible with their living donor, they're again relegated to that waiting list. But for these patients, there are some options. And one of the options, if they have a live donor, is kidney exchange. You may or may not be familiar with this concept, but imagine, as you can see on the schematic here, that a donor and recipient are ABO incompatible. A donor wants to give to an O recipient. We also have another pair that has a positive HLA cross-match, which means an O donor that wants to give to an A recipient, but they can't do that. They would be blood type compatible, but they're HLA incompatible. If you find them and you swap them and you have donor B give to recipient A, donor A give to recipient B, you can make two compatible transplants happen. You take two people off the waiting list. You help two live donors sort of realize their dream of helping a loved one. We started this around 2000, and the problem is when we were doing this, there was a question of whether this was legal or not, because in the US, the National Organ Transplant Act, which governs everything we do, forbids sales and purchasing of organs, but it was written by lawyers, and so it's phrased as you can't exchange a kidney or an organ for valuable consideration. And we asked the Department of Justice, and they said, well, exchanging a kidney for a kidney might be valuable consideration, so you all might end up going to jail for doing this, and none of us wanted to do that. And so we wanted to change the law to explicitly allow kidney exchanges, but the law was a congressional law, so we needed an act of Congress to do this. Another problem was it was unclear if we were going to do this nationally, how best to match all of the people up across the United States so that we can ensure the most number of transplants that happen and ensure that these are done in a fair manner. So we turned to math for some of this. To get Congress to do something, well, I guess the first bullet point should be a miracle. And then the second bullet point is the kinds of questions that you're going to be asked by legislative assistants on Capitol Hill. And the questions that were asked were, how many people are we talking about that would be affected by this? Why are you bothering me with a law that will affect 3 people? How many people will benefit if we do this? So how many lives will be saved, and what will it cost? Because every bill in the United States gets a score from the Congressional Budget Office. And these are the people who really run Capitol Hill. And if the CBO doesn't like your bill, thinks it's too expensive, it's going to get destroyed. Unfortunately, well, fortunately for us, kidney transplant actually saves the government money, because every time we do a kidney transplant, we get somebody off dialysis. And so that, within a year, they're already saving money because of the cost of dialysis. And then they also want to know, what is the political risk? And political, as I learned by sort of walking around the Hill, doesn't mean the policy risk. It means the risk to their particular constituents. So somebody down in Arkansas might very well ask you, and it might very well sound like this, now, is this really going to help only the people in New York and hurt the people in my town of Arkansas? And so you need to show them that they will benefit as much as anyone else will from the policy. Unfortunately, going into this, we had absolutely no data about how many incompatible pairs there were out there, what they looked like, etc. Because if somebody is blood type incompatible and the person is sitting on dialysis and they say, my brother wants to donate to me, well, what's your brother's blood type? He's an A. Oh, well, sorry, you're a B. It's not going to happen. We'll just put you on the waiting list. This doesn't get recorded anywhere. This gets dismissed at the dialysis center, at the kitchen table, at the nephrologist office, etc. It doesn't get put into the registry. So we had to do a simulation, an interesting simulation, where we basically simulated the generation of incident ESRD cases, and then we simulated potential donors that they might have, drawing from national data on what we know about donor relationships to recipients, what we know about probability of finding a donor, what we know about HLA inheritance and things like that. And then we would run a simulated cross-match and a simulated ABO test on these simulated patients. And if they were compatible, we put them into the left bin there, the direct donation bin. And if they were incompatible, they stayed in the incompatible bin. And we ran this simulation over and over again until we reached 6,000 patients in the direct donation bin. That's the number of live donor transplants that were done that year, meaning that whoever was left in the incompatible bin would have been the people who were relegated to the waiting list with an incompatible donor. And then knowing those phenotypes, we were then able to plug all of this into what's called an integer program optimization. As much as I would love to torture you with the math, we unfortunately don't have a lot of time. But suffice it to say that this is the kind of mathematics where we can put in all the information that we know about all of the different incompatible pairs. And we can come up with a formula to tell us if you swap them in this way, you're going to get the most transplants done with sort of the most priority. And for those of you looking here, you can probably see that if we match pair 1 and 3 and match pair 2 and 4, then we get everyone transplanted. If we only match pair 1 and 2, then 3 and 4 are kind of out of luck, at least for a while. Imagine doing this with 1,000 pairs, and you'll see why we turn to mathematics. What we were able to do is show that the potential impact of kidney exchange, kidney pair donation, on living kidney donation in the US was profound, and that we estimated about 1,500 to 3,000 patients every year relegated to the deceased donor waiting list who had a living, healthy, but incompatible donor, and that we also estimated that about 50 to 75% of them would match in a kidney exchange if done on a national level. Now that would be the biggest growth of live donor transplantation in the United States in decades. So this got some media attention, and I was shocked to learn that the people on Capitol Hill don't read JAMA and the New England Journal, but instead they read Time Magazine and the Washington Post. And so the media exposure is actually what got our bill some traction. The bill was written, named after the Congressman Norwood, who was a transplant recipient, and then the bill was signed by that gentleman and may have been the only wise decision that he made in 8 years. The bill allowed an explosion of kidney exchange in the United States. So you see sort of where we were in number of kidney exchange transplants before the bill was written, and you see a huge growth of kidney exchange since then. And we're doing about 700 or 800 transplants per year through this modality, and we expect that when it gets fully disseminated, it will be closer to 1,500 to 2,000. I'll switch gears a little bit. For the same patients who are incompatible, there's sort of a rockier road one can take as well. This is from the root burn track in New Zealand, and not an easy track to do either. Desensitization is a way by which we can eliminate circulating antibodies and actually take on the incompatibilities head on and allow for successful engraftment. And it's something that is being done. But there were a couple of problems with desensitization as well. One was that insurance companies wouldn't pay for it, and I'll tell you why. And two is that the regulators in the US were a very regulated environment in solid organ transplantation. The regulators tried to shut down our incompatible transplant program. And why is that? Because if you take on an incompatibility head-on, these are data from 22 centers performing incompatible transplants in the United States, and you see that the black dotted line is compatible transplants, and then green, blue, and red are incremental HLA antibody strengths. And the higher your HLA antibody strength, even if you do a successful desensitization, even if you know what you're doing, the higher the strength, the higher the risk of graft loss is for the recipient, and the higher the risk of death is from the transplant. So that you could see might be problematic and might cause insurance companies to say, well, why should we pay for this? Your outcomes are worse, and might cause regulators to say, why should we allow you to do this because your outcomes are worse than compatible transplants? But the thing is that we were asking the wrong question. The clinical question for a patient at hand is not, do you do better with desensitization than with a compatible transplant? Because if somebody came to me with a compatible donor and an incompatible donor, obviously we'd use the compatible donor. So anyone considering desensitization has only a donor with whom they are incompatible. And for them, the question is, do they do better or worse with desensitization than with their next best available option, i.e. waiting on the waiting list for a compatible donor? And so that's where, again, we turned to big data. So in the kidney exchange situation, we were turning to data to inform a simulation and then inform a mathematical algorithm. Here we were turning data to find what in epidemiology we call counterfactuals. These are people who looked just like the patients we're studying, but didn't undergo the desensitization. And the nice thing is we have records of every single person who started dialysis in the United States, every single one of them who joined a waiting list, and what happened to them on the waiting list, whether they got transplanted, whether they died, et cetera. So we could look on that waiting list to say, well, maybe there's somebody else with the same degree of sensitization, the same physical phenotype, the same attributes, but didn't get desensitized on that day. Let's see how they did, and then let's see how the people who got desensitized did. So instead of comparing incompatible with compatible, we're now comparing incompatible with something that they can actually, that's an option actually available to them, which is to wait. And what we found, and we just published this in New England Journal, this is data from 22 centers again, and you see the top green line are those who received incompatible kidney transplants. They underwent desensitization. And then the two lines below them are sort of various views of their next best available option. The waitlist or transplant match controls are people who looked just like them on the day they got desensitized, stayed on the waiting list, some of whom got transplanted. And then the lower line are those who stayed on the waiting list, none of whom got transplanted. So you get sort of a intention to treat comparison, and then you get a biological comparison. And what you see is that while desensitization is worse than a compatible transplant, desensitization is twice as good as whatever next available option is to those patients, thereby convincing insurance companies that actually we were doing people some good and convincing the regulators to get off our backs. On the donor side of things, this is Sydney obviously, and yes, I did take this photo. On the donor side of things, we have tens of thousands of individuals every year, healthy individuals, who come to us and say, I want you to do an operation on me that I don't need because I want to help a loved one. Well, we can't do risk-benefit ratio in these patients because medical benefit is zero. And actually, Murray, when he got his Nobel Prize for doing the first live donor kidney transplant, talked about this burden on the clinician of putting somebody through an operation they don't need. Well, what can we give them? We can give them at least risk awareness. We can make them aware of what the risks are of what they're doing. Unfortunately, we're terrible at that as well. We don't really have, up until a couple of years ago, didn't have any clue what to tell them in terms of their risk of ESRD. For example, I was taught that in clinic what you say is, if you donate a kidney, your risk of ESRD is lower than the general population. Well, that's idiotic. The general population is not screened to be the healthiest people in the country. The general population has disease, so obviously their risk of ESRD is going to be high. What you really want to know is, what's your risk compared to had you not donated a kidney? The other problem is that in 1965, when Joe Murray started doing this, this is what donors looked like. Today, this is what donors look like. And so we have to better understand the impact with all of the other comorbidities that they bring to the table. If I were to donate a kidney, what I would want to know is, for the major outcomes, what is my absolute risk? What is the extra risk I take from donating? And what is that for my particular exact phenotype? The problem with studying ESRD and death in donors, and this is a good problem, is that it's very rare, which means you need thousands of donors to see one event. You need tens of thousands to estimate this risk with any degree of confidence, especially for individual phenotypes. You need a non-self-reported source, and you need national representation. So you really need to look to big data to do this. Fortunately, in the US, we actually have a registry of all live kidney donors since 1988. It's massive, it's unbiased because it's all live donors, but it's useless. And what do I mean by that is we only collect the information about the donors before they donated. We don't have outcomes through this database. However, in 1994, we started collecting enough information that we can actually do linkage studies. And I'll tell you about linkage studies to Medicare data, where we know if somebody got ESRD or not, and to the Social Security Death Master File, where we know if somebody's alive or dead. So we can look at these two hard outcomes, ESRD and death, using very validated and robust big data systems, which were not made for the study of live donor risk. We also have a registry called the National Health and Nutrition Evaluation Survey, which was a cross-sectional study of Americans, about 30,000 of them, all who got complete history and physicals, lab tests, etc., but were never followed thereafter. And what we were able to do is to look through their charts, identify people that we would consider healthy non-donors, and do the same linkage on them. The first study we did, we published in JAMA in 2010, where we looked at the perioperative risk of death from donating a kidney, and we were able to estimate this to be 3 in 10,000, and we got some subgroup estimates as well. And then we compared live donors to healthy matched controls, and we followed them over 12 years, and what we discovered was that there was no increased risk of dying from donating a kidney, whatever it is that happens to you physiologically. At 12 years, actually, more of the donors were alive than the matched healthy controls. What we were able to do 4 years later, after finally linking to ESRD data, was to compare the risk of ESRD in the donors compared to healthy non-controls. And unlike the message we were sending in the past, it turns out that donating a kidney actually is associated with a higher risk of ESRD than your healthy matched non-donor counterpart, which is kind of self-evident, particularly people who are donating kidneys, because you're giving up a kidney, obviously you're going to have a higher risk of kidney disease. The key is estimating what this risk will be. If you said to somebody your risk is 27 per 10,000, that's pretty low. They may be okay doing that on behalf of their loved one. We've also collaborated with the CKD Prognosis Consortium to get a better set of healthy non-donors drawn from cohorts of millions of patients which were collected for totally different reasons. And through that, we've been able to create a calculator, and this is real and this is online. This was just published in the New England Journal, where we can take an individual phenotype and say, okay, if you have these characteristics, if you don't donate, this is your lifetime risk of ESRD. If you do donate, this is your lifetime risk. Obviously, these are estimates. There are limitations to these, but they help with patient counseling. The last thing I'm going to talk about is something interesting for transplantation, which is that patients, rather than in general surgery, where their question is really, do I undergo this operation or a different one? Do I undergo this operation or medical management? For us, it's, do I accept this donor offer, or do I wait for the next available donor offer? This photo is from Oxford, by the way. And for patients, this is a difficult decision to make. And so what we've done is created some decision tools for different kinds of organs that they might face getting organ offers from, and assistance tools to say, well, if you take this, this is what it'll look like. If you don't, this is what it'll look like. And one of the categories of organs is the infectious risk donor. So transplanters who take organ offers know this donor well. You know, this is somebody who was found dead on the street with a needle in their arm, risk of hepatitis C, HIV, etc., within the window period of detectability. In the US, this is 20% of our donor pool is classified as infectious risk, which means having a risk of HIV or hepatitis C. And the discard rates are twofold higher for these organs than their non-infectious risk counterparts. But that seems kind of wasteful, because we have a list of 120,000 people. It seems like someone on that list would probably benefit dramatically from these organs, even in the face of a small increased risk of an undetected infection. We can turn to decision process modeling, what some people call stochastic modeling, Markov modeling, and we can combine what we know from observational data. So in transplantation, we can estimate time to transplantation, death rates on the waiting list, survival of the allograft after a transplant, etc. We put those into some fancy mathematical models. We add to those things that we draw from other sources. So for example, we have cohorts of injection drug users where we can estimate the daily risk of seroconversion to hepatitis C for that individual. And so we can take those data, not drawn from transplantation at all, add those to the decision process models, etc., and then do what are called microsimulations, where we take the universe in this similar way to what I showed you with kidney exchange, and we put them through these simulations. And the way they work is you have a decision up on the left. You see, do I accept this risk kidney or not? And then if I do, I'll end up in one of various states. It'll either be clean, or it'll harbor HIV, or it'll harbor hep C, or both. but I'll have a transplant, and that transplant may fail, and I may go back on the waiting list, etc. If I say no, I start on the waiting list, that's W. I may get transplanted, that's T. I may die. Everyone eventually dies. And so you run these simulations, and you can estimate for people not just the 5-year survival, but what the entire shape of the curve will look like. And then we have a calculator. Again, they can go to a website. This website works. We use this with our patients. You can see the characteristics of the recipient. You enter the characteristics of the donor. And then it gives them essentially, I'll keep it simple, it gives them 2 curves. The top curve says, if I accept this organ, that's what my survival will look like. The bottom curve says, if I decline this organ, that's what my survival will look like. And you can tell if you can imagine if the curves are superimposed, then you tell the patient, well, you're okay one way or the other. If the curves look like this and there's a huge 20-30% difference by 5 years, and you see that they already gained their advantage before the 12-month period, then you can say, well, here's your survival curve. Does this sound like something you'd like to take? And what this has done has launched our hospital actually to be the #1 utilizer of these organs for the last 8 years, because we have a tool that effectively communicates this to the patients, as well as giving the providers the comfort of knowing that they're going to give their patients some survival benefit. So I've given you sort of a potpourri of ways that we've used big data to create high-impact work in transplantation in terms of affecting policy, doing comparative effectiveness research for different surgical procedures, linkage studies to estimate risk, and decision process modeling to help patients make decisions. Hopefully, you'll see that this is not entirely transplant relevant, but can generalize to the decisions that patients make and that we make policy-wise across the spectrum of general surgery. I would like to acknowledge my research group who's working hard at home to continue this work. And thank you for your time.
Thanks very much. Well, I feel a bit sheepish, really, after that demonstration of high-powered, high-volume data, because I'm not sure that we have the same thing in this country. This is a Department of Health project called Getting It Right First Time. If I press the right button, that would help getting it right first time. And this is essentially a clinically led quality and efficiency programme under Lord Carter's umbrella in the Department of Health. It's a 3-year programme across 11 specialties. I'm going to gallop because I know that time is short. And this really has been driven, I'll move across that, this has been driven by work done in the orthopaedic area by Tim Briggs. He's gone with his results, taken them to the Department of Health, and has now expanded the programme to run out these specialties. If we look at what they found in orthopaedics, orthopaedics have got much better data sources than we have in general surgery. They've got their joint registries, they've got their PROMS database, they've got a lot of information that they can draw on that we really do not have in the same way. What they found within the orthopaedic world was a tremendous amount of variation, and a tremendous amount of variation in the quality of care. So, for example, your risk of getting sepsis on your joint replacement varies between 0.2% in the best performing unit to 5% in the worst performing units, and there were actually units that were even worse than that. If you just brought that sepsis rate down to 0.2% across the board, you would save the NHS £300 million a year. What they found was a lot of part-time practice, if you like, with redo total knee and redo total hip replacements. The vast majority of these operations, which are technically the most difficult things to do for the orthopaedic surgeons, the majority of these operations were done by people who were doing fewer than 10 a year. Now, who amongst us would want to go to an orthopaedic surgeon doing that volume of work for that complexity of case? Medico-legal costs per consultant episode varied from naught in highly performing trusts to £151 per consultant episode in the less well-performing trusts. There has been an absolute explosion in orthopaedic procedures of unclear value. For example, subacromial decompression has increased 700% in 10 years. We're seeing the same explosion of techniques in pelvic floor work. We're really very unclear about the values of these procedures, but they are being done, and they're being done really without a clear registry of the sort that we've just heard about. The use of prostheses. The average trust had something like 15 different hip prostheses at varying costs. The orthopaedic surgeons were using uncemented prostheses in elderly patients with no benefit and huge cost implications. So there was an awful lot of variation and a lot of practice that needed to be challenged. Within general surgery, we've defined general surgery as abdominal surgery. We've excluded transplant, breast and endocrine. And we've gone to the publicly available sources of information, which includes the HES data, the big audits run by the societies, the SWORD database kindly let us use their data as well. We've also looked at reference costs. We want to include medico-legal data and PROMs, but we are yet to be there. Of course, the only PROM that we have in general surgery is the hernia PROM, and even that has got its detractors. So the way it works is we derive all this data, distill it into a report, send it to the trust, and we then go out and visit the trust. We're well aware of the fact that a lot of this data is not accurate. We're well aware of the fact that some of the data that we've collected is certainly not right first time. Interesting, there's been a tremendous range of response from the trust. So at one extreme, I went and met with half a dozen surgeons and absolutely no administrators. And at the other end, I met with the entire top table of the administrative team and no surgeons. So just the way in which British hospitals respond to an approach like this is highly varied. So here are just a few of the sorts of things that we show people. This is collected by the National Bowel Cancer Audit Project to show that across the board in this country, your risk of being readmitted to hospital within 3 months of a colorectal operation is 20%. So 1 in 5 of our patients gets readmitted. Not one single hospital has been able to explain to me what those patients are, what's wrong with them, or collect the data, or tell me what their data show. One hospital out of 22 so far thinks that it can tell me its wound infection rate. Our basic understanding of the morbidity of our operations is very, very limited. But the evidence from the hospital episode statistics is that there's a very significant problem here. If alone we set about this and started reducing our avoidable morbidity, that would be a big first step. So in America, because of these big databases, they've become very, very aware of this. The surgeons are measured on their surgical site infection rates, their readmission rates, and they are hauled up in front of their hospital management if those rates become excessive. And even worse, they will lose their insurance privileges. We really have to get a grip of this. For example, stopping our cancer patients smoking for a month will bring their wound infection rate back down to normal, yet we don't. We continue to be driven by the 31-day target, pushing through substandard care with the things we could do to make the operations safer. We look at the 18-month stoma rate. If you have a rectal cancer operation, your likelihood of having a stoma at 18 months is 50% in this country. Now, about a fifth of those will be because they were intended to have a stoma, but 30 out of the remaining 80%, almost 40% of that group, have a temporary stoma that is effectively permanent. This was something that I was completely unaware of. I certainly didn't consent patients for this when I saw them, but that is what we're doing in this country. And you can see that there are some units there in the red dots who are much, much higher prevalence of stomas. Now, a stoma will cost you £5,000 a year to the health service. This is another thing. If we look at the use of preoperative radiotherapy in rectal cancer, you will see that there are wild variations in terms of what treatment you get at the hospital. The same thing applies for esophageal cancer too. The highest using chemoradiotherapy network uses 80% of patients get chemoradiotherapy, the lowest network 20%. So there are it's almost as though you're tossing a coin if you're a patient. If you go to a high radiotherapy unit or a low radiotherapy unit, you have no real idea of what sort of treatment you're going to get and what basis it's derived upon. This looks to me, quite honestly, as though the whole concept of the MDT has failed to standardise care. Anti-reflux procedures. This is something that can be done as a day case. There are 3 units that are doing large volumes of these as a day case, and everywhere else is sitting there. So very, very slow propagation of change. If you've got a perianal abscess, your ability to have this done as a day case is it varies colossally. So there's just no consistency of the way we manage these patients across the country. And the best place to have a perianal abscess is Bristol. Acute appendicectomy. There are hospitals out there that are getting these patients in and out of hospital in less than 48 hours, in up to a third of patients. And yet there are others where they're struggling to do it, 1 in 10. The length of stay is about 4.5 to 5 days for appendicitis in this country. One of the big problems that we have is coding. We heard about this registry in the States. The coding of emergency general surgery is woeful. If you look at this, a page from a hospital report, they appeared to have only 11 patients with acute cholecystitis in a year and 672 with non-specific abdominal pain. It was a small hospital, I grant you, but that is just a ridiculous number. And the reason why this coding is so unreliable is because we do not help our coders. We put question marks in front of diagnosis, which means they're uncodable. We put ultrasound reports that say consistent with cholecystitis, which is uncodable. You cannot. The coders have very, very simple rules that they have to follow, and if they do not follow them, they get fired. They know what's wrong with the patient, but because we've not given them the information they require, they cannot code it. So a really big message coming through loud and clear is that the hospital episode statistics for emergency surgery is very unreliable, and we do not help it to collect the data accurately. If you look at what treatment you're going to get, again, it's just completely random. It's surgeon and commissioner-centered, not patient-centered. So if you've got an inguinal hernia, your chance of getting that treated laparoscopically as a primary operation for a primary inguinal hernia repair varies from 0% in some hospitals to 34% was the highest proportion so far that I've seen. Completely dependent on whether or not your surgeons like to do it or whether or not your commissions will allow it. It's got nothing to do really with patient choice or evidence. If you've got acute appendicitis, your likelihood of having that treated laparoscopically varies between 30% roughly and 90% depending on which hospital you go to. I've been to hospitals which say we laparoscope the women, we operate on the men. I don't know what evidence that's based on, but that's what they do. There is just no consistency across the piece to what we do. One of the spin-offs of this project is identifying areas of really good practice. This is the Bournemouth fluid chart, where they have had a couple of incidents of fluid problems. They've got now an individualized fluid chart that is tailored to you, is a rigid protocol that's enforced with the house and backed up by teaching. This is the sort of thing that ought to be in use across the board, and yet with our fossilised health service, it sits there in Bournemouth in splendid isolation and has not got out wider. I commend it to you. So looking at big hospital data, we've got tremendous variation in the quality and the provision of care. It's not at all clear to me whether or not the patient is the centre of care or the doctor. And I'm afraid that we have very, very little site-specific knowledge of the morbidity of what we do, i.e. the quality. M&M processes are inconsistent, although there is good guidance on how we should do it. But we need to go further than that, really. I just don't think this is, I think, as this man says, I don't think it's acceptable. We simply cannot tolerate a situation where we do not know what the morbidity of our procedures are, where we do not know how well we're doing. Not one hospital that I have visited knew how it was performing with relation to the rest of the world. And all of them were really pleased to hear, even though the data is imperfect, at least they had something to start to work with. But we need to go further. Now, one of my slightly more left field ideas is that poker should be part of the national curriculum. And this is the basics poker textbook that you need to read if you want to start. A central concept in poker is that the name for a weak player is a fish, and if after half an hour at the game you can't see who the fish is, it's you. So, there are no prizes for seeing who the fish is in this company. It's me. And it's not because he's world number one, so is she, and so is he. And I'm a completely average bum surgeon. It's because you know how good they are. They are measured, they are measured, they are measured, and I am not. They are coached to get better, even though they're the best in the world at it. I'm an average bum surgeon. I look after people and put their lives at risk. And I've had 3 episodes of coaching in 19 years. How is that a way to improve my performance? But in order to improve your performance, you've got to know how well you're doing. So here is me as a screening colonoscopist, where we do actually have some data collection, and I don't do enough, but on the whole, I'm in reasonably green zone across the board. And as an intestinal failure surgeon, when I look into my metaphorical mirror, that's what I see. I'm like a surgical vampire. There's absolutely nothing there that tells me how well I'm performing. Not a sausage. And it's just not acceptable. How can I possibly improve if I don't know how well I'm doing? It really matters. This is a really important study that Berkmeyer published looking at technical surgical performance of a morbid obesity operation. This is a collaborative who all do the same operation. They each, 20 surgeons filmed one operation and then sent it in for marking. And they got marks on a variety of things, artistic impression, technical merit, and derived a composite score from 5, nearly 5 at the best, to just over 2.5 at the worst. But when they plotted this technical surgical performance against the morbidity in their database, they found that the least technically able quartile had twice the morbidity, almost twice the mortality, twice the reoperations, and the returns to hospital. All of the outcomes were worse for the patients in the care of the surgeons who were less technically able. Now the response to this is not to tell them off for being bad surgeons, it's to coach them and help them to get better, because once you've got data, you can see where you need to improve. And the answer, I am sure, is coaching. But can we do it? Not even close. So to summarise, most hospitals in this country have got absolutely no idea how well we're doing, and the hospital episode statistics are unreliable and need to be sorted out. We need to help our hospitals understand how we're doing. We really do not have a grip, I think, on our morbidity. As a colorectal surgeon, I know I have patients with acute renal failure admitted under the physicians, but I can't tell you how many. It's just a problem I know is there. But we've got to get a grip and do this more professionally. Coding, we've got to sort out. If we were a big business, we would have a big quality assurance department ensuring that the quality of our product was fit. We have no quality assurance department, and our product, I suggest to you, is not as fit as it could be. Thank you very much.
As John and Dorry have just shown us, it would be lovely to have data that we are able to interrogate in that nature. We've already seen over the last few weeks how data used by Jeremy Hunt can be interpreted in many different ways, but if we had access to data like that, we could change the world, as it were. But how much data do we have as surgeons? John's shown us the vampire in the mirror, and that's very true. If I ask you all how much data you keep on yourselves, you might be able to tell me how many of the major resections you do. But you probably wouldn't have much data beyond that. I suspect you won't have data on the outcomes of those patients, and I suspect that of the smaller operations that you do, you perhaps don't even keep the numbers of that. If we ask the trust whether we could have some of that data, again, you're not likely to be welcomed by the pony-tailed member of the team who's already looking at the trust audit and trying to do much better things with his time than giving you data on your own operation rate and readmission rate. We can go to companies like Dr. Foster, who can provide us with some of this data, but it costs a lot of money, and you get a snapshot of a moment in time, and you can't interrogate and play with that data. So the problem, even when we can get data, is isolated static reports. It costs a lot of money, it's not interactive, and we can't interrogate it. Well, there are no comparators of how we're doing compared with our colleagues and our other trusts. So with this concept in mind, Mark Vipond, who's president of ALS, and a company called Methods Analytics, we set to work to try and set up a surgical workload outcomes research database, SWORD. The concept was to use HES data, which is nationally collected data, as you've heard earlier, less reliable in emergency, but a lot of the data, as Dorry's alluded to, is getting better and better, and in fact, at an elective level, much of that data is now very good because the trusts are paid according to it, so the data entry is getting much better. And what we want to do is allow individuals to compare themselves and trusts between each other and to be able to interrogate that data, and we use it for appraisal and revalidation. We wanted it to be led by surgeons, put in to be able to set up the fields that we want to access, and to be retained by surgeons so that we can show the data that we want. Methods Analytics have a reputation already with the College of Surgeons and ASGBI, and done a lot of work with them. And in fact, one of their key members is an ex-surgeon himself, trained as a surgeon. And with pump priming from ALS and Augis, and now funding from the other societies, we've been able to take this much further forward, and it's in a robust state. We started initially with just 3 projects: cholecystectomy, anti-reflux surgery, and hernias. But now we're up to 8 projects, and we have another 4 or 5 coming through very shortly. So I'll take you through an example. Have we got a pointer? Or is a mouse available? Of what it looks like. So when you log on, you have an individual password, and you're logged on, and the computer recognises that it's you that is logged in there, so your own individual data will come up. This is the standard screen. This happens to be for cholecystectomy. You can see that there are various time periods at the bottom, and the national number of cholecystectomies in that year was 66,000. Thank you very much. You can alter the years, so you can look at a greater number of years, or if there's only been a quarter, it's updated quarterly, so you can look at quarterly components for that current year. So it's very it's very time recognition. So we can alter the laparoscopic or open, we can change the elective or emergency fields, and you can go into detail and find out exactly how that was written. So for instance, for cholecystectomy, we've excluded patients who've had malignant cholecystectomy for a malignant operation. We've taken out all the bile ducts, so we know what we're looking at, and you can see what you want to look at. There's a standard set of metrics down here which relate to activity and readmissions and reoperations, and there will be a bespoke set of metrics. So for instance, here you can see how many of your cholecystectomies are operated on for patients with acute cholecystitis within 10 days, or pancreatitis, or whatever. As you drill down, you can see that we go through into by region, and if we drill down further, we can take it down to individual hospital level. Now this collects, because it's HES data, it collects all NHS patients wherever the hospital is. It doesn't collect any private data. We can change the field and look at the average length of stay, for instance, and we'll put in a metric here which tells us what the average is, so you can see the variation. Of course, variation doesn't mean that it's wrong, so these independent units here will be almost certainly have no emergency surgery, whereas these larger hospitals will have emergency cholecystectomies. It just shows variation. It's the interpretation, Mr. Hunt, of that data that's important. So we can look at the readmission rates here. It's 2-day readmission rate, 30-day readmission rate. And we can drill down further. At the next level comes down to independent surgeons. Now, we've pseudonymized this, so you as, when you get your login, you will be given a reference for your own individual pseudonymized code which stays with you, but you don't know what anyone else's code is. So there is a high level of independence here that we're not sharing with everybody. And we have different views. This is a funnel plot of cholangiograms, or you can look at the bar chart, and the funnel plots are available with confidence levels where appropriate. And there's another view, which we call the consultant view. So if you click on that button, it now recognizes your individual pseudonymized number, and it groups together all your data. And this time, you can change the operations in the code here, and it will group all your data whichever hospital you go in. Now, this surgeon operates in several hospitals, and we can look at his average length of stay, short stay, day case rate together or in the individual hospitals. And you can see that's the university hospital there, which is the orange one, obviously has lower short stay rate because there's emergencies in it, and it has a longer length of stay and longer day case rate, lower day case rate. And we can look again at individual things. So the ratio of emergency to the proportion of this surgeon's work, 12% of his lap choles are done as emergencies. He does 96% of his cholecystectomies as open choles, laparoscopic choles. Of the choles, the patients who are admitted with cholecystitis or pancreatitis, he manages to operate on 40% of them within 10 days. His conversion rate and his on-table cholangiogram rate. So it's a stack full of data that you can play with. But it's more than just about that individual. So when we look at this graph here, which John's shown several examples of for colorectal thing, this is acute cholecystitis variation rates. So the number of patients admitted with acute cholecystitis and the proportion of those patients who are operated on it. And it's a random scatter plot, as John's alluded to in other things. You have a very small chance of getting your operation done in some of these hospitals, but quite a high chance in those. So with introducing this idea of variance, you can ask yourself the question, or your trust, or your hospital, am I different? Do I know why I'm different? What does it mean? And am I comfortable being different? It may be perfectly acceptable to be different. If you're in an elective hospital, you wouldn't have any acute emergency operations. But is it right that in these two hospitals, you have a less than 4% chance of having your gallbladder removed on an admission, compared with 20 or 30% up here? I'll just give you another few examples of what we can do and play around with data. Lap hernias, John's mentioned earlier. These are your activity volume for all hernias in this particular region. And what proportion are done as laparoscopic? These are percentages, so very high in some centres, middling, very little chance of getting a laparoscopic hernia repair here. And you might want to ask how many actual numbers there are. And we can again show that in a different format. In a funnel plot, we can, it knows at which hospital the surgeon who's looking at this data is, so it highlights that in green. Or if you hover on a particular hospital, then it will tell you what that hospital is and the rates in that hospital. And looking again at individual surgeon rates. Anti-reflux surgery, again, we can look at the average length of stay there. If we remove the open operations to just make it more pure, obviously there's no emergency operations here, we can take out the open ones. The rates are still better, but still quite a variance there. Twice as long in this hospital as in this hospital. And as John's alluded to there, the number of patients who are getting day case rates is very variable, virtually none in these centres, up to 30% here. And we can see that in time, in this West Midlands, not only the number in any individual hospital, but also the other hospitals are increasing their day case rates. So perhaps there's some dissemination. We might choose to go and go back to Heart of England here and say, how do you manage to do day case lap fundoplications and spread that word? I was an expert witness for a medical legal case on a bile duct injury, and the surgeon on the other side swore categorically that it was unacceptable and negligent not to perform a cholangiogram on any patient having a cholecystectomy. I was able to show him that only 9.5% of patients in this country having an elective cholecystectomy have a cholangiogram rate. It's useful for all sorts of data. A hepatojejunostomy done on a patient who's had a laparoscopic cholecystectomy in a different hospital is a pretty good indicator, within a period of 2 weeks, is a pretty good indicator of a bile duct injury. And we can use some of these specialist bespoke metrics to identify where those injuries are happening. And if you're in this trust, you might want to know why you've had 5 hepatojejunostomies in patients who have had lap choles in 1 year. So we've started to branch out, and we're starting to, as we've got more time and the system is getting more robust, we've been taking on some work from other units. ACP have asked us to look at ileoanal pouches for ulcerative colitis. It's a slightly different format, but again shows fantastic data that they didn't know. They had a 40% accrual rate from their own self-collected data, but they had no idea where all the operations were being done. And you can see that over 2/3 of centres who are doing pouches do less than 5 a year. You can drill down into the units. Now they chose to, for their own data set, to limit it to a minimum of 5. So if you have less than 5, you're operating on less than 5, they don't show the actual numbers there. But that's up to any individual group that works with us as to what they want to disclose. So the next larger project we're doing is for HPB and OG resections, which we did have, again, self-collected data for August, but again, the data sets were very incomplete at 40%. So we're trying to refine this data set so that we can get a national data set. And as John said, we need to improve on the data that's going in. And interestingly, for the first time, HSCIC, who are in charge of OPCS coding and ICD coding, have approached us to surgical groups to help work with them to improve the coding sets. But we'll be able to, this is the prototype for the liver sections, which we're just stress testing at the moment. Same format, and you can change here the degree of operations, so more major or less major resections, the indication for colorectal metastases or gallbladder cancer, for instance, open or laparoscopic, and various other variables. The next data set's coming out in the next few weeks will be bile duct exploration or the endocrine surgery, and then after that we're looking to work with ACP for funding for the colorectal and perianal surgery, and the paediatric surgeons have come on board to launch a few projects as well. But we've got a lot more that we can do. We've given you here a lot of fairly standard metrics that we should all have access to, but we have the opportunity to really take this much further, and we're working on some of these things. So we will be able to look at the rates of cholecystectomy, for instance, in a population and see the variability across there. We'll have the national averages on the consultant view as well as in the standard views. It's a technical issue. We'll be able to risk adjust, particularly for the cancer work with Shimmy or Charleston. We have been offered the ONS data, Office of National Statistics. So at the moment, HES data only collects mortality up to 30 days, but this will allow data collection longer term. And we'll be able to offer you visualization with color intensity coding. So just a few of those. We can do Kaplan-Meier scoring for your cancer resections, for instance. A variable life adjustment display. So here, if this was data from an obstetric thing, where a 10% difference from an intervention done around the time of birth made a difference in survival in this Indian study. So if your baby survives, it's showing you the expected versus the observed death rate. If the intervention works, then it goes up 0.1, and if it goes down 0.9. And if you look over time, what it shows you is that this line here would be the standard that you're expecting. This would be a better than average unit, and this would be a worse than average unit. And you might want to put confidence levels on, and this is done in cardiac surgery already. Once you start dropping below 20%, people might want to raise the question, is there a problem arising here? We might want to look at, for instance, fundication. Why are these areas having much higher rates of fundication than other areas? Or it might be useful for a centre in West London here that is able to determine where its referrals are coming from. So I think that hopefully there's a little bit of light on the tunnel here, taking us out of the desert of data deficit, and that hopefully over the next year or so, you'll all be able to log into your ASGBI website and access some of this data. Thank you.
So, to give you a sort of heart sink of where I am to begin with, for those of you who caught a bit of it, I'm the National Director for Disease Registers and Cancer Analysis in Public Health England. And in the words of Ronald Reagan, I'm here from the government and I'm here to help, are probably the most heart sink things that you'll ever hear. What I want to talk to you about in the next 20 minutes, though, is what we're doing in the way of cancer data collection and how things are different. You've heard from the two previous English speakers, not that they didn't speak English, but people working in England, is that getting data out of the NHS is difficult. And many of you will remember we've done things like Connecting for Health when we invested something like £12 billion in trying to modernise our healthcare data systems. And actually at the end of that, all we'd done was invested £12 million. What I have been doing for the last 20 years is trying to collect much more rich, comprehensive data on every cancer patient across the whole of their care pathway as a resource for all of these other things. So from patient care, research, commissioning, quality, safety, audit, outcome monitoring. And the driver for this is that if we are going to deliver high quality care for cancer patients, we need to understand their care across the whole care pathway. But more than that is that as we move towards personalised medicine and the ability to treat an individual based on their genome and the way they respond to therapies, so we need to understand how that individual patient fits into the population of patients. And the problem we're finding is, of course, that individual patients are now essentially all rare. So when it comes to, when it comes to being able to find a patient who is like the woman sitting in front of you in clinic and identify how they have responded to treatment, you need to have very, very large population data sets to be able to identify the other 3 or 4 people who may be similar to her in the way they've responded to treatment. And that's the challenge we've got, is how do we do that for every member of the population? So one of the reasons I went into the cancer registries is that actually this is quite a hard problem and you needed certain properties in the place that you went to collect the data. The nice thing about cancer registries is they've been around for a very long time and they're therefore very well established. And well established in the civil service actually is means essentially boring. Boring is good though, because one of the biggest challenges we face is that actually political change, incentives, this is a very hard problem. How do you get data on every individual patient when actually you're trying to do things over a period of 5, 10 years when the political cycle is much faster? So what we've been doing is using the cancer registries as a place to get the data. We have expert staff in there. The other thing that we have in cancer registries, which is hugely valuable, is that we have legal permission under what is now Section 251 of the NHS Act 2006 to collect patient identifiable information on any individual with a diagnosis of cancer or a reasonable suspicion of cancer without the need for informed consent. And that allows us to go into acute providers, to talk to the Caldecott Guardian, to get record-level data with NHS number, with postcode, with date of birth on individual cancer patients. And what we've been doing is using that and those powers to bring data into the registration service and join it up at a record level. So what I'm going to do is take you through a care pathway here, which shows you care and cancer care from primary care through to palliative care, and show you the sort of range of data sources we use. So within screening, we can get access to the breast, bowel, and cervical screening programs. We have a process data, we have individual clinical data out of those systems. There is a single bowel cancer screening system, as we've seen this morning, where we actually can monitor the performance of individual clinicians and individual patients. For the breast screening service, there are 82 breast screening units around the country, all of whom use the same system, and we've developed systems to pull data out of that. For cervical screening, it's more complex. There is both lab-based systems, there's colposcopy systems, and you can see in yellow here, we've built data extraction processes from each of those individual clinical systems. I'll come back to how it is that we've built those and how they work, but the other things we then get access to are process data. So the Health and Social Care Information Centre runs a thing called the Diagnostic Imaging Dataset. So anyone who has an imaging investigation done anywhere in the NHS is recorded in the Diagnostic Imaging Dataset. That is hugely valuable to us when we're beginning to look at cancer stage and improving cancer stage quality, but it's also useful for us, for example, in follow-up. So if we can cross anyone with a cancer diagnosis with the Diagnostic Imaging Dataset DIDS, we can look for new imaging activity in someone who's already got a diagnosis of cancer, in which case we can begin to look for episodes of relapse and recurrence following a diagnosis of cancer. We can also intercept the cancer wait times dataset because anyone on that dataset potentially has a diagnosis of cancer. And so we can begin to follow the care pathway. We also have a slight interest in HES data, but as we've heard many times this morning, the problem with HES data for us is this coding is not accurate enough, it's not timely enough. It takes 2 to 3 months for us to get up-to-date HES data. And so what we actually do is we intercept the secondary care data feed from every acute provider on the 25th day of the month before it actually goes to the HSCIC and they process it and join it together. And that gives us OPCS4 codes, it gives us ethnicity, it gives us routes to diagnosis, it gives us demographics on every individual patient that we can then join together. Where the real value comes for us, though, is pulling data out of individual clinical systems. Traditionally, histopathology has been the diagnosis of choice for cancer. It's not entirely true now. Imaging is clearly very important. There are other diagnostic modalities like cytology. But what we wanted to be able to get on every cancer patient was full-text histopathology reports on every cancer patient diagnosed in the population. And so what every laboratory now sends us is that full-text histopathology report on every cancer patient. What we also get is we get feeds from every multidisciplinary team meeting. So every week there are about 1,700 MDT meetings discussing every cancer patient in the country. We get every feed from those systems, whether it's Somerset, whether it's Infoflex, whether it's an Excel spreadsheet, whether it is another one which is called Bespoke. We pull those out of every individual acute provider. I'll talk to you a bit about the chemotherapy feed. We've just taken over radiotherapy data collection. We run, directly through the system, some of the HQIP funded audits. So we don't run EMBER-CAP, but we do run the National Prostate Audit, the National Lung Cancer Audit, and the new Breast Cancer Audit that is due to go live in the next few months. Will all be collected directly through the system. And I'll show you some of the examples of the data collection for that and the data output. We link to imaging data, molecular analyses, and all of this data comes together. And I'll explain to you how we actually do this in a few minutes. We also link to the Office of National Statistics. And so every Thursday, we get a feed from the ONS of death cards of anyone with a diagnosis of cancer or who has previously had cancer and has now died. So we can do vital status update on those patients. We push back into primary care and we can link into the CPRD dataset if we wish, or we can send specific requests to individual GPs when we're following up a cancer diagnosis of patients. So all of that begins to produce for us a registration dataset. We then abstract all of that data and link it to other resources, for example, National Cancer Patient Experience Survey, patient-reported outcome measures, all at a record level, all with a dataset. all of the palliative care data set, and where we're now going is linking to other data sets, for example, primary care prescription data. So one of our challenges, we know an awful lot about the diagnosis of cancer patients. We know a lot about being able to follow them through. The real challenge for us is things like comorbidity. How do we understand the comorbidity of those individual patients? As we heard from John, we could use HES data, and we do use HES data, but the coding of HES data is noisy, it's inaccurate, and difficult. What we wanted was a good objective measure of comorbidity, and so one of the things we're working on is how do you use primary care prescription data on every primary care prescription item given to a cancer patient prior to diagnosis and post-diagnosis to be able to infer comorbidity and infer patient-reported or at least outcome measures. And so we're just about to link to that data set. There are around 96 million prescription items allocated every month. We've got a system that will allow us to do that from NHS Business Services, and so suddenly we will be able to plot comorbidities before and after. We're interested in radiology dosage and imaging dosage through IRMA and radiology reports, and we've got some work going on around that. And we obviously link in to Genomics England. So the challenge for this is how do you get this from across a system where there are so many disparate systems? There are no standard systems across the NHS, and the way we've done this essentially is turn the model on its head. We no longer bother to worry about data sets. We don't go into an organization and impose a data set on people. And the reason for that is basically we've learned from experience. If you try and produce a minimum data set, the first thing you do is you get into a huddle and you have a group meeting like this, and the group meeting goes on probably for 2 to 3 years, and after 2 to 3 years you come out with a data set definition, and it's a dictionary that is about 1 inch thick, and what that dictionary is probably 80% of what you wanted to achieve, because you couldn't actually compromise on the last 20%. The other problem you've got is it's obsolete, because it's taken you 3 years to do, so it's not what people currently do now, but all you've got is a data definition. At that point, you have to go around every individual organization and ask them to change to implement your data set and change what they're doing. It's a route to madness, sadness, and despair, but it is the traditional model. Because, of course, you always ask the question, how do I compare like-for-like data? So actually, we decided we'll do it differently. What we'll do is we'll go to an organization and say, do you actually collect any data on your patients? Do you collect their name, their address, their postcode, their NHS number? Do you collect their diagnosis? Do you collect some treatment data? And we'd ask them, and of course, by the time you'd ask them all this, actually most of them were quite offended. Of course we collect all that data. So we then say, well, can we have it? And they'd say, you can't. It's not allowed. It's our data, information governance, confidentiality. So we say, well, actually, we do have permission under Section 251 to have patient identifiable data on those patients with cancer. We arrange to get the data from them. But the problem is the data is a different format from the one we want. So what we've then built is transform systems that map their data set to a common vocabulary. And we do that on a common basis across all of the systems. And we map into a markup language, a bit called like XML. It's called YAML, and it stands for yet another markup language. And that allows us to take their data into our system. And we do that across the country. We pull out of 500 local systems, 1,700 MDTs every week and join the data together. We pull out something like 6.8 million records, clinical records from MDT systems a year, 1.8 million pathology records. This is the process that we then went through, is that this is what we used to do in the east of England, and between 2011 and 2013, I ran a modernisation programme across the cancer registries to change the way that they all work, so that we all worked in a harmonised way across a single system. Now, those of you who are familiar with cancer registries and cancer epidemiology will know that they don't like change. And as David has said, I come from Cambridge, there's a nice phrase used by the Cambridge colleges, which is, a little change is good, no change is better. And the model for cancer registries is much the same. So it was a fairly major change management project that involved not just the registries, but actually all of our providers. And we have 142 acute providers, we have data exchange agreements with all of them, and just as an idea of scale, 12 national feeds are processed, 500 local feeds, 1,700 MDTs. We take chemotherapy from 142 providers, molecular testing labs from 22, 82 breast screening units, 56 Linaxes, 2 million clinical records a month, 14 million historical data, and inside that is a data set of 180 data items at a tumour level, on the core data set items, and when you start adding in the other data sets, for example, patient-reported outcome measures, HES data and other things, you get to around 1,000 data items potentially on every tumour. And we register around 356,000 tumours per year. Now, in order to do this, we built a system. We don't work with system suppliers, we built it ourselves inside the NHS. It happens to run on Oracle backend at the moment, but we'll get rid of that because it's too expensive, and move to Postgres. And this system, called Encore, which stands for the English National Cancer Online Registration Environment, processes all of this data, brings it into the system, matches it to the NHS number, and then, in order to get the accuracy we're interested in, sends it off to cancer registration staff across the country. I have 100 cancer registration officers scattered across the country in 8 regional offices who take every bit of data here and quality assure it and link it. We serialize all of the back-end data and we abstract from it the data items we want for the data set, and this performance process is monitored, and I get performance metrics for every individual, for every tumour, for every office, every week. And I can watch this happening in real time as we're registering data from every acute provider on every cancer patient in the population. We then abstract the data into what we call the cancer analysis service, and we can produce outputs from that on a regular basis that feed back into the service, and I'll show you some of the outputs of that. But it's by feeding data back into MDTs, to individual clinicians and elsewhere, that we can do that. The other problem cancer registries had is that they lived in a sort of historic time warp, in that they would take a year of cancer registration data, say for 2014, and by mid-2016, in fact July this year, we would produce a single data set showing you incidence and mortality for the cancers diagnosed in 2014. That is very useful for epidemiology. It isn't very useful for anything else. So what we've been doing is pushing our processes earlier, and this shows a progress chart from date of diagnosis for a range of data sources received by the registry. And what you can see here is pathology, patient administration system, cancer wait time system, ONS systems, MDT data, we'd have chemotherapy data, radiotherapy data, all coming in within a matter of weeks of the date of diagnosis. What we're now in a position to do is take patients diagnosed in January 2016 and start processing the data in April 2016. So we're working 1 quarter behind. That allows us to get a registration on, but the challenge for us is that there are things like staging data that will take a lot longer to come through. It takes 6 months to get formal staging data. For example, in colorectal cancer, you may have adjuvant therapy, you may not go to the definitive surgery. Once you put in the 62-day wait, all of those things are going to take time. You have to wait a lot longer. So we build a record, but you're on the system within a quarter, and then you're followed up for the rest of your life for data collection. We're obsessional about some types of data, because asking other people to tell you the data gets you the wrong answer or something that you can't interpret. So if you're interested in cancer, you want to know something about the stage at presentation. The problem with stage at presentation is you can do that by imaging, you can do it by pathology, you can do it at the MDT, you can do it post-treatment. If you simply send us a TNM, all we know is you've sent us a TNM, we don't know whether it's TNM 5, 6, 7. So what we do is we now understand the provenance of all staging data we've been given, and inside the registry we've trained up registration officers as experts in staging, overseen by Dr. Brian Roos, who's a national staging lead and sits on the WHO panel, to make sure we get everything right. And over the last 4 or 5 years we've been driving up staging completeness. And here you can see that in 2011, for registry-derived stage for the top tumour sites, we were fairly low. We then focused in 2012 on the International Cancer Benchmarking ones, in 2013 on the Public Health Outcome Framework, and in 2014 we're looking at stage completeness of around 90% for the top 12 tumour sites. You're never going to get to 100% because not all patients can be staged, they're too sick, they die. So 91% is about where you are. So for 2014, this is what the data collection looked like. 227,000 staged solid tumours, 50,000 still waiting to be staged, 19,000 from sites that are not staged, such as haematology and some brain tumour sites. Non-melanoma skin cancers currently at about 115,000, but actually I think there are around 200,000 still out there, and we're just about to try and get those. Non-invasive conditions like Bowen's that we didn't include, and 7,000 were outside England. The story of chemotherapy is a nice one because it shows much of what data collection where you don't worry about data standards is about. This is chemotherapy. Chemotherapy given to every cancer patient in the country is a data set that used to be 42 data items, and of course a crucial bit of those data items is the regimen that you actually give. So 100% of regimens are actually complete. Here's a standard coding problem. There's no uniform electronic prescribing system in this country. So what you discover is that of all of those regimens, everyone describes them differently. And so in Leeds, for example, David Dodwell, who's our lead oncology chemo physician in Leeds, as a breast physician, would be giving David's chemo regimen for Friday afternoon. That isn't a universal standard, but it works extremely well for David. So what we did when we started was we then said, we've got all the data, let's now map it centrally to a common regimen. And that's what we did. We went from 35,000 regimens down to 686. Took us 6 months to do, but we were then in control. Unfortunately, at that point, they said, oh, hang on, we've created another 13,000 regimens while you were doing the rest to be got rid of. So now we run a dynamic process so that every month, every week actually, we can see how many new regimens have been created by each acute provider. And as those new regimens appear, so we map them and correct them. That process now runs in the background. So that's some of the data collection we do. We also do data collection for the national audits, for lung cancer, for prostate. We feed back that data to the clinical teams. At its simplest level, we simply say to you, you've sent us a file. Here's some data I collected last night. I thought I'd go to Southampton, since that's where David is, and look at completion for the National Prostate Cancer Audit. This is data that went onto the system in May 2014. It's reporting on activity for, May 2016. It's reporting on activity to March this year, and is showing the completion of data set items, one after another from each of those data sets, by clinician, by MDT, and you can drill down to surgical details here, whether the lymphadenectomy was performed, what proportion of patients, what cases were in there, and you can then go to a patient level and follow those through. That's for a national audit. For other things where there isn't a formal national audit, we've now got clinical headline indicators where we're able to look at a whole series of metrics for different things, and again, right down to outcome, death, complications, all of that data is beginning to come into the system. We're also collecting screening histories, and we go around the entire screening service every night for every breast cancer and try and find the screening history through the screening process. We bring that in, allows us to do follow-up, ECOM audits and other things from the screening histories. But data is only useful when you actually start doing something with it. And so what I want to finish with in the next 2 or 3 minutes is just show you some examples of data out at different levels. The first, as we've seen before, is that you can produce predictive models based on the data you know about. And this is one we produced some years ago with Gordon Wishart, Paul Farrow, which is the PREDICT model. It's very similar to the adjuvant model built in the US by Peter Ravdin, but this is the added benefit of adjuvant chemotherapy for people with breast cancer. This is available, open to the public and to clinicians. It's used by about 5,000 people, I think probably about half are clinicians, half are patients every week. And allows you to look at the added benefit of adjuvant chemotherapy. We can now produce many more of these, and we'll begin work on them. The next thing we're looking at is how do you follow individual patients through the system? Because timeliness, outcome, mapping of patients is crucially important. So what we can actually do is we can take the data points of a patient on a referral pathway and begin to look at them. And so what we can build, simply in Excel actually is one way of doing it, is simply a stacked bar chart of the time taken for each of the intervals for every cancer patient, for every tumor type across every provider. This is a pool of all of the breast cancer patients treated in the East of England over a 6-month period, sorted for date of referral to date of diagnosis. And you can see changes in time, and you can then drill down by provider. And at this point, you can see that there are 2 providers here, one of whom seems to have a significant delay in the time it takes to get from the diagnostic event through to the MDT. It turns out this is probably a data anomaly, but it begins to get you where you want to go. You can then map that into cancer stage and outcome. You can map it to an individual clinician, and you can map it to chemo or other interventions. We can follow the patient. We can follow the organization. We then want to follow the clinician. One of the other things we've done is pulled our data out into what's called a graph database, which is very similar to the type of database that is being used to do social media interactions through Facebook, through Twitter. And what I'll show you next is a screen grab of a single consultant episode, or a single consultant. We put in a GMC number that happens to be for Mark Emberton, and he's allowed us to do this, which shows Mark's patients, he's a urologist at UCL, and all of the patients he's seen in a year and what he's done to them. And you can see on the left-hand side, you can then drill down. You've got Mark in the middle here as the center of the universe. All the patients that are attached to him, whether he's done surgery on them, they then have chemotherapy, then treatment, then provider. In a graph database, we can do these processes extremely quickly. This sort of query takes a matter of seconds to do, and you can pivot around this, link it to other data items and other things. Where I wanted to finish is where many others have talked about, which is HES data. One of the challenges for us is understanding the real patient and patient notes. And one of the things I used to do when as a pathologist, or all of us have done in clinic, is when you're sitting in clinic and you've got a stack of paper notes in front of you, before you even see the patient, you know quite a lot about them, even if you don't open the notes. When it says volume 3 on the front of the notes, and they're thick, and they've got multiple different dividers, what are sometimes called polychromatic patients, because the tabs are all in different colors, you've got a feel instantly of what sort of patient you're about to see. What I felt we'd lost in our system was an understanding of what do our digital patients look like. And so one of the things we've built is a viewer that allows us to see what does a patient feel like when I pull their record in from HES, from the cancer data set, and begin to get a feel. Now, I can show you this online, but actually what I'll do is just a few screen grabs. Here is a single patient, female, 81. She's patient number 99 in our ID. She lives in Manchester. She's had CA breast. It's not been staged. She's got Charleston score 4, deprivation score. And this is a combination of her HES data and her cancer registry data, where I can list all her diagnoses, all her operations, how many times she's come into hospital. What I can then drill down with is actually a graphical view of the patient pathway and all her referral episodes. And here is a timeline of all her referral episodes since about 2001, of all the activities. And I can mouse over each of these, and you can see in the blobs down the bottom the various disciplines. She clearly had a run of hematology. There's some general surgery. And I can drill down individual ones of those. I can also zoom in on individual areas, and the little grey box here in 2010 is showing me simply those 10 or 15 episodes in that 3-month period. And then I can mouse over each individual one of those to take it forward. What I think we've now done is essentially managed to go from digital records back into paper records. So to finish, what we've created in the cancer registration analysis system has taken us a year. It's a system-wide change. It's not just inside the registries, it's across the entire service. But we now have one of the most comprehensive, detailed, and performance systems for monitoring cancer care anywhere in the planet. And we can use this for monitoring outcome and surgeon performance. Thank you very much.
A fantastic opening session to the Congress. I think those of us who have been here this morning have been very privileged to hear how the world is changing. There are challenges, as John has pointed out. There are successes, as Dorry and Jem have pointed out. And there are particular successes for surgeons, as Ian has pointed out. I hope we've collected this data on video, so we'll be able to look at it again. I'm asking the speakers to produce synopses that we will publish in the association newsletter. I'm grateful to all four for staying around this morning, and please go and talk to them. They're a fantastic resource of ideas, information, forward-looking, thinking men, and I'm most grateful to them for coming. So if we could just give one last round of applause, and then please pile in and talk to them. Thank you very much.